Good evening to all of you. I welcome you all for today's Wednesday webinar. As you all know, we're entering the last month of 2023, and Stroke SIG will be taking over the academic activities this month. And as has been the tradition, we'll be having a group of case presentations today, mainly on the stroke mimics. I'd like to request our President, Dr. Shefali Gulati, to introduce the experts for today's session, the moderator for today's session. Over to you, ma'am.
Yeah. Thank you, Mahesh. Welcome to the 29th webinar in the series. And for the stroke, we begin the stroke with the stroke mimics, because all that looks like stroke may not be stroke. So you have to be very clear about what are the possibilities. And we have case presentations from across India. And in future webinars, we will seek presentations and cases from other attendees from outside India as well. And they can mail to AOC and India email ID, which Mahesh will let them know in the end. And today to discuss, we have three experts. Dr. Brahim Tabarki Malaiki is a very renowned consultant pediatric neurologist from Riyadh. And he is, he has a lot of interest in, metabolic disorders especially, and has very world-renowned and invited speakers for more than 200 sessions, and a lot of index publications and chapters and books, and really grateful for him to have joined. Thank you. Then we have, can I have the next slide, please, Bansi? Dr. R. Lakshmi Narasimhan is Director Professor of Institute of Neurology, Madras Medical College. Right now, he's joined the Ramchandra Institute of Medical College, and he's a very well-renowned adult neurologist with a lot of equipment for the clinical science and all. He would be joining shortly because of the for the cyclone which has hit Chennai. He doesn't have internet connectivity right now. He's moving to a location where there may be possibility of his to join. And we've requested Dr. Manish Parekh is going to be our third expert. He's a renowned pediatric neurologist, and with having a special, he's been trained from Canada and he's working in Jodhpur, and he's basically, his interest is stroke as an epilepsy. And the moderator for the session will be Dr. Harsh Patel, who being my student and alumnus from our place. He's now currently practicing as a consultant pediatric neurologist in Zydus Hospitals, Ahmedabad. And he's for this stroke SIG, he's the secretary. Request that we have lot of, and he's, we have a lot of cases today. So I would request Harsh to be very strict about the time, so that it is, as we decided, is 6+4, 6 minutes for presentation and 4 minutes for discussion. And my request to presenters are, the idea is to just prime everybody. You are not teaching everything. You also have to learn to stick to time, and that much present, so he'll tell you at 5 minutes. Dr. Harsh, please tell at 5 minutes, and then at 6 we close, so that we just discuss, and just it's just a priming for everybody to take interest, and it's not teaching anybody, the details and the pathogenesis. The messages will be given, so that everybody broadens the horizon for the same. And all of you will be sent by email, certificates of participation. And like we had the quiz last time, we will have a quiz in stroke one of the Wednesdays. We will let you know on that very Wednesday when we have. So I am handing it over to you, Harsh.
Yes, ma'am. So
I request you to be strict from the beginning, because otherwise, if you are not strict from the beginning, like Ranjit, you have Ranjit to emulate, right? Ranjit was very strict, sure. Right? So you'll have to be strict, because it's not justified for the last ones, Yeah.
Exactly. Yeah, so our first speaker will be Dr. Suman Das from North Bengal Medical College. I am sharing his slide on behalf of him. Dr. Suman Das, you can start once slide has been shared. Okay?
Yes, sure, sir. Yes, good evening, everybody. My respect for all the faculties and experts. Today, I'm going to present the case of a 2-year, 4 months old boy who had normal growth and developmental history, but he presented to us with a history of low-grade fever for 1 day. On the next day itself, he developed left-sided hemiparesis, for which he was admitted. And soon after admission, he had one episode of seizure, which was left-sided focal clonic with secondary generalization. Now, at admission, the DCS was 11, which improved with therapy, and he was found to have left hemiparesis as the only focal neurodeficit. deficit. The next slide, please. Since this patient had a new development of a neurodeficit in close association, temporal association with fever, we considered the possibilities of infection-associated complications. It could be stroke due to para-infectious arteriopathy, or it could be para-infectious demyelination. The next slide. Now, we did a non-contrast CT at admission, which showed that there was a wedge-shaped hypodensity in the right temporal lobe. Now, this wedge-shaped hypodensity, we initially thought that it could be due to occlusion of the M2 or the M3 portion of the right middle cerebral artery, or it could be due to embolic phenomena in the leading to infarct in the cortical watershed zone. There was also hypodensity along the perisylvian region in the right cerebral hemisphere. The next slide. Next slide, please. Now, the contrast CT showed that there was florid leptomeningeal enhancement in the please the contrast slide. Yeah, the previous one, please. The previous slide, please. Now the contrast CT showed that there was profuse leptomeningeal enhancement in the area of the hypodensity. Now at the close look also showed that there was subtle leptomeningeal enhancement on the left side also. In the next slide, it will be seen. Not only the right, but the left temporal lobe also had subtle leptomeningeal enhancement. So we were postulated that this could be due to the blood-brain barrier breakage in the portion of the infarcted tissue, or we could not also rule out any inflammatory pathology. The next slide. The next slide, please. Since the patient had leptomeningeal enhancement on both the cerebral hemisphere, we considered that there could be a possibility of a diffuse inflammatory process inside the brain. This inflammatory process could be an infective etiology or a non-infective etiology. The routine tests were all normal. The infectious screen of blood and urine cultures were normal. The malaria, dengue, scrub, and chikungunya were also negative. Now we did a CSF which showed 2 lymphocytes. The glucose was normal. The protein was mildly elevated, but the cultures and the CBNAT were negative. The next slide. The next slide, please. Now, the MRI we did, we got the MRI but 1 week after admission, and it showed that in the T1 there was subtle hypodensity in the right temporal cortex. The T2 showed that there were subtle hyperintensity in the subcortical temporal white matter, and there was also in the lower panel marked by the blue arrow, there was also hyperintensity along the right insular cortex. And the next slide. The next slide, please. Now the flare, it also showed that there was a definite hyperintensity in the right temporal cortex compared to the left, and as well as that there was hyperintensity in the globus pallidus and also in the putamen. So now, viewing this MRI, we were often the possibility of infarct was ruled out because the DWI did not show any abnormality. The GRE was also normal, and this involvement of the medial temporal lobe, the insular cortex, and the parts of the neostriatum showed that the limbic system was involved, and we considered the possibility of an inflammatory lesion. Either it could be an infective inflammatory or a non-infective inflammatory lesion affecting the limbic system. The next slide, please. Now the MR angiography was normal, the echocardiography and the ECG was also normal. Next slide. Now we received the CSF PCR which was positive for herpes simplex encephalitis. Now we treated this patient with acyclovir injection for 21 days, and apart from that the seizures were controlled with loading and maintenance dose of levetiracetam. Now with this therapy the child became alert, playful, and the limb power improved, and he was discharged on oral levetiracetam and physiotherapy. Now 10 days later after discharge, March, this child developed hyperkinetic movement disorders. And this hyperkinetic movement disorder comprised of chorea athetosis, dystonia, hemibalismus, and orofacial dystonia. The child was also having features of encephalopathy, and that he was not feeding well and no interest in usual plays. Now the next slide, the videos. I have the videos of the hyperkinetic movement disorder. Please, the videos. Please play the videos. Yes. Now this video will show that the child was having continuous athetosis movement in all the chorea movement in all the forelimbs, and there was also dystonia in the distal part of bilateral upper limbs. Now the next slide. Now, this will show that the child has very gross orofacial dyskinesias, and as well as the coriform movements are occurring in all the forelimbs. And there is also hemibalismus movement in the right-sided upper limb. Now, since this child was having gross new onset movement disorders, we repeated the MRI, which showed that there was an atrophy of the right temporal cortex. The contrast showed that there was still subtle contrast enhancement in the left, in the right temporal lobe. Now, since this patient was having features of limbic encephalitis following herpes simplex encephalitis, we considered the possibility of an autoimmune encephalitis occurring in a post-herpetic state. Now, the next slides. Now, this flare also showed that there was asymmetrical atrophy of the right temporal cortex with medial temporal lobe and the insular cortex hyperintensities. Now, the ELISA was negative for the panels which we tested, but since this patient was having acute onset the behavioral problems and movement disorder, along with the supportive features like new onset CNS neurodeficit and new onset seizures and MRI features of limbic encephalitis, we considered this case as a possible seronegative autoimmune encephalitis, and we treated this patient with IV methylprednisolone. But there was no response. We treated with IVIG, yet there was no response. So we were compelled to treat this patient with rituximab. Now, we treated this patient with 375 milligram per meter squared, first dose, 2 weeks later, second dose, and third dose 1 month later, then 6 months and 1 year later. Now, within 1 week of the therapy, this child started to show improvement. His cognition improved, encephalopathy was resolved, and the movement disorders were completely resolved within the next 3 weeks. Now, the repeat EEG showed that there was only right temporal delta slowing, but in previous EEGs had showed that there was high amplitude delta, which was present in a generalized fashion. We were at 1 year follow-up, and the CD4 count is less than 0.1, and the child is currently asymptomatic. So our final diagnosis was that it was HSV encephalitis triggering seronegative autoimmune encephalitis. The take-home message is that all hypodensities in CTs are not infarcts, and there are many unidentified antibodies, which and a negative panel should not delay immunotherapy, and steroids and IVIG may be insufficient for extreme hyperkinesis, and so second-line agents like rituximab, they are needed. Thank you.
Thank you, sir, for presenting this nice case. I invite experts, Dr. Brahim, for your comment on this case.
Yeah, very nice and a very interesting case. Yes, it's a little bit classical to have. It's most likely. So we have herpetic encephalitis and complicated with immune-mediated encephalitis. So from diagnosis on day one at presentation, I think the picture is classical for herpetic encephalitis, especially if we combine the clinical presentation and the CT findings. So from the CT, I think the diagnosis is there for herpes. What is a little bit unusual is the fever is not very high, and and the seizure only once. So usually, most of the time, we have more seizure and the fever is more high, but it can be seen. But I think if we combine the clinical presentation and the CT, we can have the diagnosis of herpetic encephalitis. Then I would like to ask, so what was the dose of acyclovir and for how many days he was treated?
The acyclovir was given for 21 days.
And what was the dose?
And the dose was 10 milligram per kg body weight per dose and thrice daily. So total 30.
Okay. Okay, so the second presentation is also classical for immune-mediated presentation. We have to be careful sometimes because we have 2 or 3 cases are true relapse herpetic encephalitis. So I think we have to screen for herpes even in the second presentation. Even the picture is the phenotype is typical for immune-mediated with a lot of abnormal movement, etc. But I think we have to screen for herpes again if it's relapse or the virus is still there. So usually now we treat for 21 days. Yes, is true, but usually we are using higher dose. We are using 45 to 60 milligram per kg per day. So 30 milligram, probably it can be considered as a factor of low dose and one of the possibility that this patient evolved to immune-mediated. So the second question, why the antibody are negative? So you test the antibody in the CSF, right?
Yes, sir. The CSF, as CSF and serum, the paired sample of CSF and serum. But the thing was, we used the ELISA method, and the antibodies tested by NMDA, LGI1, Casper, and GABA A, GABA B. We have the short panel which was tested.
Yeah. So what is described is the NMDA. So what we are familiar with the NMDA as a complication of herpes, but we have to be extremely careful in the lab techniques. So if we are not using cells, culture on cells, we have to be careful in the interpretation of antibody. But probably it's a classical presentation of NMDA encephalitis as a complication of infectious encephalitis. And most of the time you see that there is disruptive brain and the prognosis, unfortunately, is extremely bad, even if we use rituximab or other modality. The prognosis probably depend mainly on the first presentation rather than on the second presentation. So I still consider that the NMDA is a possibility, even you have a negative lab, and the mimic, let us say, from day one that the CT is not typical for cerebrovascular events, so we can rule out the classical stroke, and we have to put infectious on the top.
Absolutely, Dr. Parekh.
Yeah, so Dr. Das, that was a fantastic presentation. And I think Dr. Tibarki definitely, he summarized it so well. Almost everything is, we have a patient of herpes viral encephalitis, suspected herpes, and then, we all know that they can progress to autoimmune encephalitis, certainly. This can be antibody negative, definitely. But here I would certainly also consider this may sometimes be a presentation of genetically mediated Golgi mutation, and it is a known fact that limbic encephalitis-like picture or epilepsy from temporal lobe may masquerade. In fact, Golgi may masquerade this way. So that's the only thing which I would add here. Otherwise, it was a fantastic case presentation. For those, the audience here definitely should appreciate the fact that, as Dr. both Tibarki and Dr. Das stressed, that all the hypodensities which look like a wedge shaped on a CT are not, may not be classical cerebrovascular phenomena. And we must always, so MRI is the gold standard. That's what is the lesson here. Thank you.
Thank you. Lokesh, Dr. Lokesh Lingappa, thanks for joining from Florida. Good morning. You want to
Good.
say
Yeah,
something?
no, I think it as well summarized. It's a well-known phenomena that RP simplex can be associated with an MDR. And what Dr. Suman has done is the right thing to aggressively immunomodulate post this one. And although the weakness might be very mild in this kind of situation because they don't involve so much of motor cortex, but a subtle weakness is usually a phenomena, which you see is the initial part of presentation of RP simplex. Thank you.
Thank you, Lokesh. Over to you, Harsh, back. Thanks.
Yeah, thank you all of you. Now I invite our second presentation. It is a team from AIMS Rishikesh. The moderator is Dr. Pratik Panda, and Dr. Achanya will be presenting the case. So please share your slide.
Yes, I'm sharing my screen. Sir, is my screen visible? Is my screen
Yes,
visible?
visible. Yeah, visible. Go ahead, please.
Good evening, all. I'll be presenting a case of neurocutaneous syndrome mimicking stroke from AIMS Rishikesh under the guidance of Dr. Pratik Kumar Panda, sir. We have Master G, a 12-year-old boy, resident of Bijnor, UP, who presented with the chief complaints of weakness of left side of the body for 10 days and headache for 10 days. The weakness was acute in onset, initially had clumsiness while walking, inability to bear weight on left leg, which was progressively involving left upper limb as well, had a distal predominant weakness in left upper limb and lower limb, and the weakness progressed, and the child was not able to get up from supine position, and the child was eventually non-ambulatory. It was associated with history of facial deviation to the right side with no history of difficulty in closing eyes. It was associated with headache, which was acute in onset. It was present daily, frontotemporal in location, moderate intensity, continuous throughout the day. However, it was not associated with any history of nausea, vomiting, photophobia, phonophobia, aura, or no history of any previous episodes of headache. There's no history of seizure, altered sensorium, altered behavior, no history of vertigo or trauma, no history of fever, rash, joint pain, recent vaccination, no history of any respiratory distress, no history of any blood transfusions or bleeding manifestations. The birth history, immunization history, development and family history were non-contributory. On examination, the child was conscious, oriented to time, place, and person. On the vitals and anthropometry were within normal limits. On head-to-toe examination, we can see that the child has a large hyperpigmented macule present predominantly over the left side of the body, extending from the umbilicus to the left mid-thigh, involving the inguinal region as well. There's a similar lesion present over the left gluteal region and also a macule over the left posterior mid-thigh. There's also another large hyperpigmented macule extending from the posterior aspect of left leg from the left mid-thigh till the left ankle. There was no other significant finding on the head-to-toe examination. On CNS examination, child was right-handed and had left-sided human facial palsy with hypotonia in left upper and lower limbs, with reduced power in the left upper limb and lower limb, with distal power more effective in the proximal, and had a hemiparetic gait with normal sensory examination with no meningeal or cerebellar signs. Other systemic examination were within normal. So we have a 12-year-old boy with acute onset left-sided with non-progressive headache with a giant melanocytic nevus over the left side of the body with left UMN facial palsy. So the differentials considered were hemorrhagic stroke in view of acute onset severe headache and focal neurological deficit with left ipsilateral human facial palsy. The child did not have any altered sensorium seizures or arterial ischemic stroke was also considered in view of the acute onset hemiparesis and ipsilateral human facial palsy, of the child did not have headache. So CSVT was also considered in view of the similar complaints, but the child did not have any features of raised ICP or no papilledema or no underlying prothrombotic condition. Other differentials considered was an intracranial space of occupying lesion like cerebral abscess. However, in view of headache, however, the child did not have, however, the weakness was acute onset with no fever and no signs of raised ICP. Neoplastic XOL was also considered in view of headache and neurocutaneous marker. However, the weakness was acute onset with no signs of raised ICP. We upfront went ahead with the CMRI brain with MRI in this child as a child presented with acute onset focal neurological deficit. So the MRI is showing large ill-defined lobulated multifocal mass lesions seen in the right gangliocapsular region, right parieto-occipital and periventricular region, and in the left cerebellar hemisphere as well. These lesions are heterogeneous, hyperintense on T2 flare with partial diffusion restriction and significant perilesional edema is also present. The lesion in the gangliocapsular region is involving the thalamus, and there is a mass effect compressing the upper brainstem and right lateral ventricle with a mild midline shift. There's few foci of blooming seen in the right gangliocapsular lesion. On post-contrast images, there's patchy enhancement with non-enhancing cystic component. And the MRS of this lesion is showing low NAA peak with a high colon peak. And these features were suggestive of glioma. There's also multiple nodular minimally enhancing lesions seen of variable sizes along the ependymal lining, which is having a signal of gray matter, which was suggestive of periventricular nodular heterotopia. The MRI was normal in this child. The routine investigations were within normal limits. CSF was done, which showed 5 cells with 100% monomorphs and elevated protein, and CSF, KOH, culture, CBNAT, and cytology were negative. We went in with the clinical exome in this child, as the child had neurocutaneous markers without features specific for any specific neurocutaneous syndromes. This showed a loss of function missense mutation in filamin A gene, which was homozygous and X-linked dominant inheritance. And this was reported in periventricular heterotopia, Meilding-Needle syndrome, and autopalato-digital syndrome. However, the SET-D1B mutation was also detected in this child. However, the clinical picture was consistent with the periventricular heterotopia. However, the child also had other lesions in the brain. The
1 minute remaining.
Distal truncating germline mutations have been reported in filamin A gene mutations in males as well. So the diagnosis was neurocutaneous syndrome, probably a giant melanocytic nevus syndrome with brain neoplasm, glioma with periventricular nodular heterotopia. So in this child, we had considered, we had sought a neurosurgery opinion for further diagnostic and operative management, and stereotactic brain biopsy was planned for this child. However, as it is not feasible, we are going ahead with brain biopsy, open brain biopsy in this child for the lesion. So the take-home messages are brain neoplasms can present as stroke due to hemorrhage or increasing size of lesions. So in a child with neurocutaneous markers presenting with acute onset focal neurological deficit, possibility of brain neoplasm should also be considered. Thank you.
Thank you for presenting this nice case. I invite experts for their comments.
First Pratik, the faculty in charge will like to say something. Pratik?
Am I audible?
Yeah, you're audible. Yeah.
In this case, the main issue.
You are very faint. You are faint.
Okay.
अरे बिल्कुल नहीं सुनाई दे रहा. वही ठीक था जो पहले था.
Main issue with this case was there was brain tumor, probably brain tumor. We also considered possibility of there was some minimal enhancement. Tuberculosis, since the CSF protein was a little bit higher, but the and all these things, expansile lesion, that favored neoplasm, but there was periventricular nodular head. Went ahead with the sequencing, and that showed him with X-linked dominant inheritance. But now it has been reported males have been affected with this particular gene. The main message was that even if there are bilateral lesions are present and it is a neoplastic expansile lesion, the child presented to us like a stroke. That was the main thing we wanted.
Harsh? Dr. Brahim?
Yes.
Yeah, thank you. Thank you again for this very nice and very interesting and challenging case. I think if we compare the previous case to this case is more straightforward, as the patient presented acutely with deficit. So the cerebrovascular event or compression is most likely the case. And involving also the face. So this from clinical point of view, this goes more with acute stroke. Probably hemorrhagic stroke is unlikely because the patient level of consciousness is preserved. So we think more of ischemic stroke. So the imaging showed probably there is I think it's aggressive tumor, and probably the basal ganglia involvement and the thalami involvement with the compressing the capsule is responsible for this acute deficit. So I don't think that the cerebellar lesion have role in the clinical presentation of this patient. So it's probably tumor, which we know that in patients with skin lesion are more risky to develop tumor, mainly malignant tumor, aggressive tumor. So probably we have to go through biopsy to see exactly what is this tumor. And regarding genetic, I think it's extremely difficult for the interpretation. We know that the FLNA is mainly responsible for isolated heterotopia. I am not aware is it found in tumors. So probably if you do biopsy, I think it's better to study the gene within the biopsy. So it will be more informative. Thank you.
Parik?
Yeah, so Achanya, that was a very good case. And so I really love the clinical part, because a child who presented with, so Dr. Tibarki actually answered that question. So anytime if I am seeing a patient who had an acute focal deficit, I would just like to know where the deficit is localizing. So Achanya, would you, Dr. Tibarki already told that, but can you just give us an idea about how did you clinically reach to the point where would this focal deficit localize?
So it would localize the MCA territory, sir.
Yeah, so specifically the cortical MCA, or pardon me?
Internal capsule, sir.
Yeah, fantastic. So it's capsuloganglionic, right? And I just missed the part whether the left UMN facial palsy was acute in onset, or was it existing before all this, the left hemiparesis, the upper limb and the lower limb involvement?
So it was acute in onset, sir.
Oh, so it was a part of this whole deficit. So yeah, definitely. So that's more likely that in this child it was because of the lenticular striate region, or the capsuloganglionic region which was involved. And certainly we would think of all the 3 or 4 differentials which you thought. So definitely a cerebrovascular event, and the other the etiologies as well, which you had already defined. So given the fact that in the era of the neuroimaging and the genetics part, we would certainly know what the diagnosis is, but still a lot of confusion about what the neoplastic process is. So that can be resolved, with other methods, certainly. But I would the case again stresses the fact that every time we look at an acute focal deficit, the conundrum should always include, number one, the cerebrovascular accident, the neoplastic process, the autoimmune part, the genetic part, and so forth. So nice case. And the only point which I have to stress is that we have to go clinical. So with a neurocutaneous stigmata, always think of whatever you had presented. Thank you.
Thank you. Lokesh, want to add something? Dr. Lokesh, you want to add something? Or we've handed back to Harsh. Harsh?
Yes, ma'am. So, yes, ma'am. So we can move to the third case. It's a team from ICH Bangalore. The moderator would be Dr. Venkat Raju, and the presenter is Dr. Vivek Santosh. Yeah, thank you, Vivek.
Yes, sir. Good evening, sir. Good evening, everyone. Today I'll be presenting a case of stroke mimic. My moderator is Dr. Vaikunth Raju, sir, who is the professor and HOD at the Department of Pediatric Neurology, Indira Gandhi Institute of Childhood, Bangalore. So coming to the demographic details, this is a 2-year-old male child hailing from Anantapur. Informant was the mother, which was a reliable source. Presented with paroxysmal events in the form of right focal seizures, with right-sided weakness with no facial weakness, which was preceded by a febrile illness. Coming to the previous history of this child, on day 9 of life, the child developed excessive cry, hurried breathing, and decreased responsiveness, with no history of paroxysmal events during this time. Was treated at the local hospital as late onset sepsis in ICU for 3 days. At around 7 months of age, the child was noted to have deviation of eyes towards one side with excessive cry, along with tonic posturing of limbs with exacerbated reflexes. Was advised the neuroimaging at this point of time, along with the genetic testing. Coming to the birth history, it was nil significant. Development, impression of the development was a global developmental delay with motor more than cognition domain. This child was second born to third degree consanguineously married parents, with the first child was a male child who was stillborn at around 9 months of 9 months of gestation, and there was no other significant neurological disorders in the family. Coming to the anthropometry, the observed weight was 7 kgs, which was less than -3 standard deviation, length of 72 centimeters, which was less than -3 standard deviation, head circumference of 45 centimeters, which is less than -3 standard deviation. These are the clinical photos of the child, which show typical dysmorphism in the form of wide, narrow palpebral fissures with boggy cheek-like appearance, and bilateral temporal wasting, which is also very appreciable in this case. Along with knuckle hyperpigmentation, there was no dense lens dislocation. The other systemic examination, CNS, in the form of increased tone, more on the right side compared to the left, with both dystonia and spasticity, and power being less on the right side, that is 2/5 compared to the left side, and with exacerbated reflexes, right more than left. This is the clinical videos which is showing the same, wherein you can appreciate the weakness on the right side compared to the left side, with increased tone on the right and with some amount of dystonic posturing. So the clinical diagnosis at the end of it would be a global developmental delay, motor more than cognition, with right focal seizures, with right hemiparesis, with dystonia, with microcephaly, with failure to thrive, with facial dysmorphism secondary to stroke or stroke-like episodes. Most probably would be a metabolic etiology given the clinical scenario. The differential causes of metabolic, that is the metabolic cause of stroke or stroke-like, would be hyperhomocystinemia, MELAS, MMA, that is propionic acidemia, League syndrome, Fabry disease, glutaric aciduria, B12 deficiency, and urea cycle disorders. So coming to the investigations in this child, hemoglobin was on lower side 10.2 with MCU of 85.5. Peripheral smear showed dimorphic anemia with megaloblast. B12 was 477 and homocysteine was 10.35. The other investigations, ultrasound of abdomen, which was done, no organomegaly noted with no renal calculi. LFT, RFT ammonia was normal, and lactate was elevated, that is 65.28. TMS, GCMS done in this child with the background of metabolic suspicion, that is IEM, was normal. So went ahead and did the CT, which showed hypodensity in the globus pallidus, that is left more than right, mildly appreciable on the right in this image, which is put here. Also, there is hypodensity in the left cerebral peduncle. We went ahead and did an MRI, which showed restriction diffusion, that is showing hyperintensity in the left cerebral peduncle as well as the left globus pallidus. And the other sequences, this is a T2 weighted axial section showing hyperintensity in the globus pallidus, left side more than right side, as well as the left cerebral peduncle.
Pediatric neurology, the Department of Amrita Institute of Coaching.
And coming to T2 weighted flare showing hyperintensity in the globus pallidus, left more than right, as well as the periventricular white matter and the left cerebral peduncle. It also revealed, the sagittal section also showed some mild thinning of the corpus callosum. So keeping the background, the clinical picture, MRI, CT, as well as the diagnosis of a metabolic etiology, genetic diagnosis was, genetic analysis was sent, and which revealed MOSC1 gene mutation, which was a homozygous state autosomal recessive causing molybdenum cofactor deficiency type A, but it was uncertain significance. We went ahead and did the serum uric acid, which was on the lower side. So coming to the final diagnosis, this is a case of global developmental delay, motor more than cognition, with right focal seizures, with quadriparesis, right more than left, with dystonia, with microcephaly, with failure to thrive, with facial dysmorphism secondary to MOSCS1 mutation causing molybdenum cofactor deficiency type A. So the treatment was given in the form of supportive care, levetiracetam for the paroxysmal events, and then THP, B12, B6 physiotherapy, and dietary advice in the form of low protein diet, and which is also including cysteine restricted. So the take-home message would be molybdenum cofactor deficiencies of two types, where it's of neonatal and early infancy, which is a more severe form, and the second one is the childhood adult, which is late onset and milder form. The severe, that is the neonatal form, presents a severe encephalopathy, including refractory seizures and axial and appendicular hypotonia and feeding difficulties and apnea. The childhood adulthood one presents with acute neurological decompensation in the setting of an infection, and they can also present with dystonia, chorioathetosis, ataxia, and nystagmus. So basically, in molybdenum cofactor deficiency, these are the various genes indicated. And in molybdenum cofactor type A, this is MOCS1 is one which is deficient. Hence, there is no formation of cyclic CPMP, and which causes the clinical features. So the other genes are GPHN, MOCS1, that is which we described, which is the most common type A, and MOCS2 and MOCS3. And with respect to the treatment options available for molybdenum cofactor deficiency, for the type A, there's an FDA-approved drug that is known as fosdenopterin, that is known as Nubleri, which is a daily infusion given through an indwelling catheter, dose based on weight and age. And this must be considered and initiated in a very short window after the symptom manifestation to achieve maximum benefit. The other treatment options include supportive care as well as diet, which is made in the form of low protein diet and cysteine restricted diet. Coming to conclusion, I would like to conclude saying that metabolic etiologies must be considered when the clinical presentation is of stroke or stroke-like episodes with underlying developmental delay, along with extrapyramidal features and significant failure to thrive. And molybdenum cofactor deficiency can also present with milder phenotype with onset from neonatal period and atypical MRI findings. This child presented from the neonatal time, but it clinically looks like a milder phenotype. And the atypical MRI findings from this case. Thank you so much.
Yeah, thank you for well finishing in time. I invite Dr. Venkat Raju to share his comments.
Yeah, thank you for that. So actually the differential diagnosis in this condition is very wide. So you should consider metabolic condition with associated along with weakness if there is associated development delay, failure to thrive, and other features. You should consider stroke-like episode rather than stroke. And in this condition, the stroke mimic maybe because of metabolic toxicity. Even though it is a metabolic condition, it can present asymmetric, not always symmetrical findings. So this is a very clinically it is very difficult to suspect. Maybe investigation like uric acid sometimes use, sometimes clue. It was done 3-4 times. It is coming with lower range. So genetic test is the one that does confirm the diagnosis.
So one question is asked, what made you think of stroke in this case?
Child has a weakness is there, so that is the main thing. Focal seizure with right side weakness.
Dr. Ibrahim?
It's a difficult case. So I think the phenotype in this patient is more complex than the previous one. So I think this is classical for metabolic genetic disease, a patient with developmental delay, microcephaly, etc. And the mechanism of stroke or stroke-like in this patient is we can debate about that. Is it post-prolonged seizure, or is it because of metabolic demand and energy failure, or because of some ischemic lesion in the globus pallidi? So this is possible, but definitely, so it's difficult to include this patient as classical stroke or stroke mimic. So this is one. Two, I will be extremely careful to label this patient as molybdenum cofactor deficiency. Even you have a genetic investigation which showed BOS in the molybdenum gene. I think what we have, at least the more severe type, with the type A, usually in neonatal form, and usually is very bad, with very bad seizure, with very bad brain, a lot of brain anomalies, etc. So I think we have to go either by more biomarker in the urine. I know it's difficult sometimes because we need fresh urine, or to do more testing in the family to prove that this is the pathogenic gene. Definitely, I would be more careful to label this patient as true molybdenum, but true, it's one of the metabolic genetic disease. Thank you.
Parekh?
Yeah, so one question, Dr. Santosh, whether this child was developing normally until 8 months of age when the child had the first seizure?
No, sir. There was a developmental delay. That is, initial onset of neck control was only by around 6 to 7 months. Social smile also was attained 7 to 8.
Okay. Because, one of the things which, when you said it was only the seizure which presented until 8 months of age, this is a very, very rare condition, as Dr. Ibrahim said, and you also, Dr. Raju also mentioned this is an extremely rare condition. You don't think of it. So what I would have gone for was a child is not thriving well, it's mild developmental delay, and then, he has the tonal abnormalities, has an acute stroke-like event. I would have always considered neurotuberculosis in this country at 2 years of age. That's something which comes to my mind only because of the commonness of that condition. And it can present because it also has, it is a small vessel disease, and it causes the endarteritis obliterans, which causes the stroke-like events, and it's the lenticular striate region again, which is involved, right? So that would have been one thing. And the other thing, but then, not taking away all that workup which you have done, the only thing which I would stress here is that in your differential diagnosis, you could have included congenital disorders of glycosylation as well. They also present with stroke-like events, and the presentation can be very much similar to what we had seen in this child. Otherwise, this condition without a genetic testing, you cannot put it. And as Dr. Tibarki has very rightly said, that you need a Sanger sequencing of the parents, put into the linkage analysis, and all that would be required to actually prove that, and also the biochemical testing. But then, yes, a broad differential has to be kept. More commonly, the common conditions should be thought of, certainly, and that's what we have done. Thank you. Nice case.
Thank you so much, and thank you all the presenters for presenting really well, and your preceptors to have moderated, and just reaching out to everybody participating. You can express your desire to present. Dr. Mahesh will be typing the AOCN India email in the chat, and that you can attend. I mean, you can send it by every Saturday, and we will be having interesting cases of acute stroke next week and recurrent strokes the week after. And over to you, Harsh. And there was one question left, Harsh.
Thank you.
There's one question left. There's one question left.
Ek minute. Yeah. So is Nulibri available in India, Dr. Raju?
No, currently not available.
Okay, sir. Thank you. So now I invite a team from AIMS New Delhi. The presenter would be Dr. Mona Sundaram, and the moderator would be Dr. Gautam Kamila. Please go ahead.
Yes, sir. Is my slides visible, sir? And am I audible?
It's well visible and we are audible.
Yeah, thank you, sir. Good evening, respected faculty and dear colleagues. I am Dr. Mona Sundaram, DM resident from Child Neurology Division, All India Institute of Medical Sciences, New Delhi. And my today's moderator is Dr. Gautam Kamila. So I'll be presenting a following case from our institute. So moving on to the case, here I present a 15-month-old male child hailing from Rampur, Uttar Pradesh, with the chief complaints of recurrent episodes of unilateral weakness since 7 months of age. Till date, the child had 3 episodes. So reviewing the history, the child had a normal birth history with the smooth perinatal transition, and child had a typical normal development till 7 months of age. At 7 months of age, child had a fever that was low grade and it was undocumented, associated with the left focal seizures during that febrile episode. Subsequently, child was noticed to have an insidious onset of weakness involving the left upper limb and lower limbs that was progressed over 4 days, and the child was presented to the outside hospital where an imaging was done. And the imaging done at the time of first presentation showed T2 hyperintensities in the cortical and the subcortical right posterior regions and parieto-occipital regions with corresponding restricted diffusion in the DWI sequence. So possibility of acute to subacute stroke was considered, and the stroke evaluation was done in the outside hospital. So during the hospital stay, the child was noticed to have an improvement in the left-sided weakness. But however, the child had a weakness involving the right-sided upper limb and lower limb, which was also insidious onset and it was progressive. So the imaging done at the time of second presentation showed resolution of the right-sided lesions. We can see there is a left-sided patchy diffusion restriction in the posterior parietal and the occipital regions. So now the child had a recurrent stroke under evaluation, and the possibilities considered was vasculitis or arteriopathy. And subsequently, the whole exome sequencing was done, which showed variant in the CACNA1A gene that was heterozygous variant, but however, it is a VUS. So after this, the child was started on the aspirin and amlodipine, and child was discharged. And during the next 2 months, there was an improvement in the right-sided weakness that was improved gradually. And child had attained more than 90% of a function. But again, in May 2023, that is 2 months after the initial presentation, child had a fever followed by a weakness involving again the right-sided upper and lower limb. So at this time, child visited our OPD and the child was evaluated and the history was reviewed. And during all these presentations, child had a preceding fever followed by weakness, and also there was history of vomiting. And except for mild irritability and seizures that was associated with the first episode. However, there were no other significant histories. On examination, child had low power and hyperreflexia involving the right upper limb and the lower limb compared to the left side. So imaging that was done at the third time of presentation showed T2 hyperintensities in the cortical and subcortical regions of the left hemisphere, entire hemisphere, with corresponding restricted diffusion in the DWA sequence. So it is confined to a specific vascular territory, likely an middle cerebral artery territory. So as a part of workup, the child was planned for angiography, and the subsequent imaging was done 9 days later. And during the when the imaging was repeated, it was incidental that the lesions that were initially present on the left side were disappeared. So there were resolution of lesions in the subsequent imaging. Concurrently, child was evaluated biochemically also, where the child elevated lactate of 4.7. And the investigations that were done in outside facility in the initial presentation were reviewed, which also showed mild elevation of transaminases, and there was elevated serum lactate. So now clubbing together the clinical investigation, clinical picture and the biochemical investigations, we have a male child with the history of recurrent stroke-like episodes, along with every time the weakness was preceded by fever with background elevation of lactate and mild elevation of transaminases. So when we see the imaging serially, there are multiple areas of involvement of stroke-like picture at different time points. When we see the first two imagings, there are there are diffusion restriction lesions, but it's not restricted, but it is not confined to a specific territory. In the third imaging done at the third presentation, it is confined to a MCA territory. So there are different time points, stroke-like lesions. So clubbing together the clinical picture, biochemical investigation, and the imaging, possibility of metabolic stroke was considered, genetic secondary to mitochondrial cytopathy. So as we know, the child already underwent whole exome sequencing, where it was reported to, where the child was reported to have a variant of unknown significance in CAPNA1A gene. But the clinical phenotype and the genetic variant is not matched. Subsequently, the whole mitochondrial genome sequencing was done, and which showed a pathogenic variant in the MTTV gene, and reported to have a mitochondrial encephalopathy, lactic acidosis, stroke-like episodes. And the clinical phenotype and the genotype was also matched with the matched, since the child had elevated lactate and multiple stroke-like episodes preceded by a febrile episode. So then for child was started on the mitochondrial supplements, that is coenzyme Q, thiamine, and riboflavin, and child was also initiated on arginine. Currently, child is 15 months old and is walking with support. However, still there is a residual weakness in the right side of the body.
One minute left.
Yes, sir. So a word about MELAS. So it's a neurometabolic genetic disorder due to mitochondrial dysfunction. And although 80% of patients present before the age of 20 years, 5 to 8% can present before the age of 2 years. So regarding the presentations, stroke-like episodes represents a cardinal feature that are seen in almost all patients diagnosed with MELAS, followed by epilepsy and dementia. So why there are stroke-like episodes in MELAS? The following hypothesis or mitochondrial angiopathy theory, generalized cytopathy theory, and non-ischemic neurovascular cellular theory. Thank you.
Yeah, thank you. Finishing in time. Dr. Gautam, share your thoughts.
Yeah, thank you, sir.
And there is one questions also. I'm just telling you, role of arginine in mitochondrial disorder.
Yeah, I am coming to that, sir. So the first thing is that
Stop sharing the screen so that you can be seen full screen. Stop sharing the screen. You can continue, Gautam. Yeah.
Yeah, so the first thing is that if you have an acute infarct and it doesn't follow a vascular territory, one needs to consider non-vascular causes. And in cases with recurrent episodes of stroke preceded by febrile illness, the possibility of metabolic strokes like due to mitochondrial etiology or due to methylmalonic acidemia or propionic acidemia needs to be considered. And as you have seen, MELAS is usually not common in children less than 2 years. It's predominantly seen little older children, like more than 2 to 5 years of age. But rarely there are case reports where we have seen case where there are children below 2 years of age presenting with MELAS. And one can never underplay investigations like blood lactate, and these help in aiding the diagnosis, as we saw in this case. So coming to arginine has a role in management of stroke-like episodes of MELAS. It's a precursor of nitric oxide and is used in the acute phase of the illness, and it can also be used prophylactically. So there was a systemic review in neurology published in 2022, where they have shown that around 30% of children who received oral L-arginine showed a good response in the form of decrease in severity and frequency of stroke-like episodes. So though the evidence is not very robust, but it may help. So that is the reason why arginine was given in this child.
Are you using arginine alone or combined arginine and citrulline?
So predominantly we are using L-arginine.
More question. Any role of adding L-carnitine in this mitochondrial dysfunction disorders?
Yeah, so as he has mentioned, we are giving the mitochondrial supplements in which we do add carnitine.
Ibrahim.
Yeah, I think very nice. Thank you for this very nice and very interesting case. I think from clinical presentation, so again, it's very unusual that the deficit is more progressive over is not very acute, and this is again against the vascular origin. And by neuroimaging also, we don't have clear territory. So definitely we are not in the chapter of classical stroke. And from the first imaging we have is stroke-like lesion. So the fact that they start early before the age of 2 years, that always triggered by fever, this also probably it's from metabolic or mitochondrial origin. I totally agree that MELAS in this age is unusual, but we have a few cases. Likely they respond to this cocktail and to high dose of L-arginine. But definitely it's a very nice case of metabolic stroke. And I thank you for this case. Thank you.
Thank you, sir.
Dr. Parekh?
Yeah, so yeah, very nice case. And someone in the chat box, as the case is going on, someone put in the diagnosis of MELAS, So a very typical of what happens in a metabolic stroke-like condition. And Dr. Tibarki definitely, he made it very clear that the caveats like what the others have really told, the caveats in the presentation of MELAS before 2 years of age and also when they present. So I only want to add is the fact that, again, if you are going from a clinical standpoint, Gautam, I know all of you, although again, 15 months of age, progression of a moya-like illness, the pattern. So the weakness is again alternating weakness, presenting like this. I would have thought of something going on in that perspective as well. Secondly, in this patient, it was very clear that an intercurrent illness precipitated this. So again, we have been seeing patients. So we have proven patients of again stroke-like episodes which occur because of rarer conditions, but they are common. So I have at least 2 of each of these patients. So Polji, I have again 3 or 4 patients presented exactly like this. Younger age, may or with or without an intercurrent illness, again stroke-like episodes, because Polji is a nuclear gene which encodes the mitochondrial gene, and we know it can always present like this. Then there is a condition called as perioxysomal and mitochondrial fission and fusion disturbance, and this is also a genetically mediated condition. This is not common, but I have 2 patients who presented again with exactly, there's a family with me who lost 2 of their children with progressive stroke-like events, and I don't know whether others have seen this condition or not. Then I never forget the collagen synthetic defects. Again, the only caveat here is that they would not occur with an intercurrent illness. They will present like, again, strokes in different territories and overlapping territories as well. So a combination of small and medium-sized vessels, and that would, try and nail to the diagnosis, a point towards the diagnosis, and of course requires a lot of genetic testing as well. Yeah, so good learning case. Thank you.
So thank you, sir. And
if I may add, just please.
Yes.
Just because the imaging is mainly occipital stroke, this is also a good hint for MELAS even at this age. Yeah.
Absolutely.
And considering the possibility of the small and medium vessel disorders which we talked about, so we had done a angiography in this particular child, and it was normal. There was no abnormality found in that.
Right. So one small question: how
so
you
just
can
to add,
differentiate?
I know.
Dr. Brahmin.
Yeah, how you can differentiate?
Please go ahead. And then
press in this patient from especially in the first imaging.
Yes, sir, but during that time we had the vitals had clearly been recorded, and there was no abnormality or any fluctuation in the BP records which was recorded. So, and the child did not have any specific renal disorders also, which was known. So it's very unlikely that the child would have a press in this particular condition, and predominantly it's more of a bilateral picture which we see in press rather than unilateral. Yes, we can see, but here it was very quite unlikely in the absence of any fluctuation in blood pressures and any renal disorders accompanying this child.
Dr. Parekh, you also had to say something.
Yeah, so just to add something, Gautam, here and for everybody else. So typically, a small vessel disease would be diagnosed only by a brain biopsy, and they may be angiography negative because of the larger. So Dr. Tebarki is an expert here in this area, and so your comments, Dr. Tebarki, on small vessel disease.
Yeah, I agree with you. Even so, the gold standard is biopsy, but angio may help. So conventional angio may help, and surprising, even the biopsy sometimes is challenging. Because we may have negative dura, we may have positive in the brain parenchyma. So the biopsy should include the leptomeninges, but also the small cortex, and better to be done in the frontal region. And we need good biopsy. And even with that, sometimes even it's challenging. Currently we have a case very challenging with biopsy not helping us. Yeah, totally agree with you.
So the neuropathologist is core here, but then in this case, the clinical approach would have been definitely what you did. I fully agreed. The only thing is that wider differentials would help. Sometimes so happens that you can find. So specifically with the Polgi and the mitochondrial disorders of fission and fusion.
Thank you. Thank you for a wonderful presentation and wonderful discussion. Harsh, you have to be timekeeping. Yeah. Actually, we generally don't like to have more than 6 cases, but with the amount of interest everybody gives, so we had to accommodate. So we thought that it's okay, we'll make 6 plus. Yeah.
Yeah, sure. So now we are moving to the west of the country. I invite the team from Pune. Dr. Nitin will be presenting the case, and Dr. Kavita Srivastava would be the moderator. Please share your slide. Your slides are visible. You can go ahead.
We cannot hear you, is it?
Nitin, you are not audible.
Sir, am I audible now?
Yes. Please go ahead.
Okay, sir. 14-year female child, second born of non-consanguineous marriage with normal birth and development. She was admitted in 2019 with complaints of severe pain in right upper limb, followed by difficulty in using right hand for 5 days. And there was deviation of angle of mouth towards left side for 4 days. Gradually developed difficulty in walking over the next 2 to 3 days. There was no fever, headache, vomiting, trauma, or seizures. On examination, higher mental functions were normal, and she had bilateral diminished visual acuity, and cranial nerve examination showed right 7th cranial nerve palsy, which was of UMN type, and rest of them were normal. Tone was slightly decreased on the right side, and reflexes were not elicible, and power was decreased on right side, more involving the upper limb. To summarize, she 14-year female with acute onset right-sided hemiparesis with ipsilateral 7th nerve palsy, thought of differentials as acute ischemic stroke affecting right internal capsule, unlikely to be brainstem as facial nerve palsy was of UMN type, and demyelinating lesions like edem, NMOSD and MOG, and rarely space-occupying lesion. and she underwent MRI that showed hyperintensities in the bilateral thalami, more in the left compared to right, superior part of the midbrain, cerebral, peduncle, and temporal lobes bilaterally. And to revisit the clinical differentials thought of for acute ischemic stroke, it was unlikely as there was no significant restriction on diffusion and lesions do not pertain to particular vascular territory. Demyelinating lesions were more likely because of asymmetric patchy areas of involvement without significant diffusion restriction, suggesting demyelination. Other differentials like encephalitis, secondary to herpes, and Japanese encephalitis were unlikely because of the lack of clinical picture of encephalopathy and the preceding fever. And there was no history of the SOL is ruled out by MRI. And further, routine CBC, urine, and homocysteine levels were normal. CSF protein showed elevated protein, and CSF viral panel PCR was negative. Visual evoked potential showed abnormal prolonged latency in bilateral eye optic nerve. And to revise the summary, it came out to be demyelinating disorder, clinically isolated syndrome with polyfocal involvement of brain and optic nerves. The possible diagnosis could be NMOSD, MOG antibody disease, and first episode of multiple sclerosis. MRI spine and serum and CSF antibody panel was planned, and spine MRI showed T2 sagittal showed hyperintensity from C4 level to D7 and suggesting LETM, longitudinally extensive transverse myelitis, more than 3 vertebral segment involvement. And serum antibody profile was positive for aquaporin 4. And final diagnosis of NMOSD was made, and she showed improvement to IV pulse methylprednisolone of 30 mg per kg per day for 5 days, followed by tapering doses of oral steroids. And she was advised for repeat MRI after 3 months, but there was loss to follow up. However, again, she came to us in after 5 months of duration with different picture of recurrent nausea and vomiting for 1 week, diplopia and blurred vision for 2 days. There was no fever, headache, and focal deficit and seizure this time. On examination, higher mental function was normal. Cranial nerves, and that there was, on looking to the left, there was limited adduction of the right eye, along with nystagmus of the abducting left eye, suggestive of internuclear ophthalmoplegia, and other ocular movements and tone reflex were normal. The provisional diagnosis of relapse in a case of NMOSD was made possible brainstem lesion. Internuclear ophthalmoplegia has a role of medial longitudinal fasciculus, which is a key structure for conjugate horizontal eye movement between medial rectus and the rectal rectus of the contralateral eye. Whenever there is lesion in the MLF, there is impaired adduction of the ipsilateral eye and associated abducting nystagmus of the contralateral eye during attempted contralateral movement. And repeat MRI this time showed new lesion in the area postrema, dorsal medulla, and previous lesions were recovered. And area postrema syndrome is associated with hiccups, nausea, and uncontrollable vomiting for several days in connection with area postrema attack. And this region is particularly rich in aquaporin 4, the target of anti-aquaporin 4 responsible for NMOSDs. On further course, other anti-ANA and double-stranded DNA were negative. And again, she received IV methylprednisolone for 5 days, for which there was partial response, but as in diplopia persisted, and she was started on rituximab, after receiving 2 doses. There was complete recovery in the following 2 weeks, and she was continued on oral low-dose steroid. And however, there was no relapse since then. The predictors of relapses are female sex, long spine lesion, positive ANA, anti-Rho, RA, vitamin D insufficiency, and elevated CSF IgG index. This is a diagnostic criteria for NMOSD, categorizing 2 categories. Our patient fit in the first criteria with aquaporin P4 IgG positive with at least 1 clinical core characteristics, including this includes optic neuritis, acute myelitis, area postrema syndrome, acute brainstem syndrome, symptomatic narcolepsy, and symptomatic cerebral syndrome with NMOSD typical brain lesions. These are some of the differentiating features between MOGAD, MS, and NMOSD. And there
1
is,
minute remaining.
Yes. There is in case of NMOSD, there is involvement of optic chiasma as well. In case of a MOG antibody, there will be posterior retroorbital involvement of the optic nerve, and in MS there will be patchy segmental involvement of optic nerve. The learning points are NMO has high recurrence rate up to 90%, and patient without long-term immunosuppressive therapy have worse prognosis and high mortality rate. Spine screening should be done in all children with demyelinating lesion in brain, and serum NMO antibody testing has good sensitivity. CSF does not increase the yield of the test, and the demyelinating diseases should be considered in case of stroke as a stroke mimic, and it is one of the major differentials for stroke in pediatric age group. Thank you.
Yeah, thank you for a nice case. I invite Dr. Kavita Srivastav for their inputs.
Please stop sharing the screen while Dr. Kavita speaks, please.
Yeah.
Stop
so
sharing.
here, what was very unusual? Am I audible?
Yes,
All
ma'am.
good.
Yes.
Yeah. So what was very unusual was severe pain, because usually in the strokes that we see, and of course the fact that she had facial as well as the upper limb, lower limb, and without having any encephalopathy, it localized it to the internal capsule and the subcortical regions. But what was unusual was very severe pain. And so that can be explained by the thalamic involvement here. And so initially, only the stroke protocol was done because in our institute, all the children or adults coming with hemiparesis are, and she was a little bigger child. So the CT and diffusion images were done. And of course, the flare picked up all this. So sometimes you may miss if you do only diffusion and CT scan and not do the flare images. That is one point I wanted to make. And of course, the MRI was quite characteristic. And then when we saw these images, then we asked for a spinal MRI, and which of course confirmed the diagnosis. So that's all from my side. Hello, Dr. Harsh?
Yeah, thank you,
Yes,
Dr. Kavita.
Yeah. Thank you so much.
Thanks. Thank you so much. Dr. Brahim.
Yeah, I think, again, very interesting case. I think I will highlight again the clinical presentation. I think this is the most important. Again, the pain is very unusual, and the poor correlation between the clinical presentation and the imaging. So definitely, I will say from the clinical presentation, it's stroke. It's ischemic stroke involving the one of the capsule. I don't know if we pay more attention to the visual issue. So probably the patient have, yes, decreased vision, but I don't know if there is any other symptoms and signs of optic neuritis or neuropathy as color vision or any defenders, etc. But definitely the clinical presentation as pain, as motor deficit will are typical for ischemic stroke, but the MRI is not correlating. And with the MRI, the diagnosis is clear as demyelinating, including the spine, and the aquaporin 4 is typical. But I think what is interesting in this case is the clinical presentation. Maybe we are missing something in the ophthalmology exam at presentation. Thank you.
Yeah, so on eye examination, there was actually no abnormality detected, and even the MRI of the optic nerves was also normal, but only the VEP was prolonged. It was a subclinical kind of, though she was also presenting, like complaining of little blurred vision, but we didn't find any abnormality on examination.
Maybe what is also very unusual in this presentation, usually the relapse. So the relapse as a post-trauma syndrome, this is also unusual for aquaporin 4. They may present with the post-trauma syndrome, but usually the relapse, it will be more diffuse, including the brain and the spine, and not only restricted to the brain stem. So this is also very interesting feature.
Thank you so much, Dr. Ibrahim. Dr. Parekh.
Yeah, so fantastic case. And again, Kavita has summed up that all, and Dr. Tibarki as well. So it boils down to the clinical presentation, certainly. And the clinical presentation here was atypical for a cerebrovascular phenomena, and especially arterial ischemic stroke. That's certainly there. And secondly, the localization was difficult, and then there was a temporarily a new kind of syndrome and a new lesion, which was definitely fitting into NMIST. But then the lesson learned again are demyelinating illnesses can cause definitely, if even it's an infectious demyelination, for example, in typhus, also this can happen, leptospira and conditions like that. So they also present something, the facial weakness and focal deficits. But then it's very clear that for a typical arterial ischemic stroke, it's not the presentation. And also, if it had been very insidious, as in this patient, it's sometimes so difficult to tease apart between both the conditions. But yes, the lessons learned are always there with every patient. And thank you so much. It's a wonderful case again.
Thank you so much. And before I hand over to Harsh, I want to tell everybody that all the sessions are being recorded, and even the previous 28 sessions and this session also, it will be available on YouTube. So that would be, nothing is missed. Yeah. Thank you so much, the speakers and the experts. And I hand over to Harsh for the next case, please. Harsh.
So
I think Harsh,
we are
one or two
running this
questions also left. Yeah, Kavita, can you answer those questions on online on the?
So what is the vitamin D level? And on examination, they ask color vision and this apparent APD. I think it can be answered on this
Yeah, I
alkaline
already
way.
answered. Visual examination was normal. Only the VPs were prolonged. Thank you so much.
Fine.
Thanks. Thank you.
Harsh,
So we are moving
can
to the
I add
next
something?
case.
A single point. So for everyone else, I know all of you are experts here. So Madam and Kavita and Dr. Tibarki and everybody else, So only for the neurology residents, please note that for acute demyelination of the optic nerve, the first thing to go or become abnormal is a color desaturation. Okay, so that's one thing that this should be a take-home message. So even if you have a normal visual acuity, even if you have everything else normal, the color desaturation will be the first one to be abnormal. That's pathognomonic almost for the optic neuritis. Okay, because of a demyelinating optic neuritis.
Yeah. So now we move to the next case, which is from the Dr. Mahesh Kamate from Belgavi, presenting the next case.
Am I audible?
Yes, your slide is visible and you are audible. Yeah.
Good evening, everyone, respected faculties. Myself, Dr. Akshata, DM Pediatric Neurology Resident. My moderator, Dr. Mahesh Kamte, Professor HOD Pediatric Neurology Department, JNMC Belgavi. I'll be presenting unusual cause of stroke mimic. Slide is case details. He's a 6-year-old male child from Yergatti, Karnataka. Came with history of weakness in right upper limb and lower limb. Noticed for 2 days. On day 1, he got up in the morning, brushed his teeth. While having breakfast, mother noticed that child is having difficulty in approximating the fingers, but was able to bring a hand to mouth with some spilling of food. Later on, mother asked to offer a jover to a devotee. He couldn't hold a handful of jover. They were spilling from the right side. Then later in the evening, afternoon, mother noticed that child was dragging his right foot, but he was able to climb stairs without difficulties. So first she noticed upper limb weakness, followed by in the evening lower limb weakness. And there were no history of angle of mouth deviation, drooling, regurgitation of feed or speech disturbances, and no history of change in behavior or a seizure, no history of headache, giddiness, imbalance while walking, vomiting, and no history of abnormal movements. On day 2, child was brought to the hospital, admitted, and no progression, no new deficits or a seizure. With the history, so possibility of acute onset hemiparesis with which is evolving over 6 to 10 hours, and possibility of stroke was kept. Past history, the child had URI 2 weeks back, and there was no history of varicella in last 1 year. Development was normal. Family history, he's a third order child, and born to a second degree consanguineously married couple. On examination, BP was normal. General physical examination, 6 cafe au lait macule of 0.5 to 1 centimeter. One we can see over his right upper lip, and HC and height was normal. MMSE was normal. Speech was clear. On cranial nerve examination, visual acuity was reduced due to astigmatism. Bilateral pupils were reactive. Fundus was normal. And there was slight esotropia on the right side on primary gaze, but conjugate movements were normal. And on cranial nerve 7 examination, there is mild deviation of angle of mouth to the left and flattening of nasolabial fold on the right side. But however, the closing of eyes and frowning was normal, indicating right UMN type of facial palsy, and other cranial nerves were normal. On motor examination, bulk was symmetrical in all the limbs. Tone was reduced on the right side in all joints. Power, the upper limb was more involved than lower limb, and distal was more involved than the proximal. As we can see, the gait, there is mild hemiparetic gait while walking, and there is flattening of nasolabial fold on the right side. DTR's knee jerk was brisk on right, rest other was normal. Superficial reflexes, abdominal reflex was absent on the right side, and Babinski was extensor. Cerebellar and sensory examination was normal. So this is the impression was acute onset right-sided hemiparesis, distal more than proximal, upper limb more than lower limb, with stuttering course involving first upper limb followed by a lower limb, with ipsilateral UMN type of facial palsy, with 6 cafe au lait macule, with no seizure, altered sensorium, and raised ICT signs, and with sparing of speech. With these clinical history and clinical examination, the localization would be below internal capsule and above pons. So the differentials on board were, first was TCA, because the history of fever with URI and stuttering course, the points against was speech was spared, and the localization and demyelination was a second because of fever and acute onset stuttering course, but there were no behavioral changes or seizure. Moya disease, because 6 cafe au lait macules in a prepubertal child, which was significant. Possibility of neurofibromatosis 1, which will have the moya 3 to 6%, but the points against were not involving any arterial territory or no recurrent episodes. And ICSOL, because NF1 is associated with glioma, and 6 cafe au lait macules, acute onset and stuttering course. The points against were no signs of raised ICT, and if we think of UFO, they will be usually asymptomatic. And the last was mitochondrial, because second degree consanguineously married couple and one child was lost due to febrile illness. But the point against where development was normal, and there were no recurrent episodes. We went ahead with MRI. So we can see the T2 images where there is a well circumscribed expansile lesion arising from midbrain to thalamus and hypothalamus. Diffusion restriction, but there was no reversal on ADC. T1 isointense to hypointense, and on susceptibility weighted images there was no blooming, and contrast there is no enhancement. Angiography was normal. So in view of possibility of glioma, child was referred to NIMANS for a stereotactic brain biopsy. Child was operated last week on Thursday, and the biopsy reports are awaited. So tumor mimicking stroke, the intracranial tumors may present with sudden onset of stroke-like symptoms called as tumor attacks. 3 to 5% of brain tumors can present as acute stroke. Among them are gliomas, meningiomas, and metastases are the most common intracranial tumors masquerading acute stroke. The majority of the gliomas mimicking stroke are glioblastoma, which belongs to WHO grade 4, and few case reports of grade 3 also. And they are easily detected on contrast CT or a MRI. The possible explanation for acute presentation of tumor are: one is post-seizure paralysis, acute intracranial pressure changes with subsequent reduction in cerebral blood flow, vascular steal phenomena, acute hemorrhage, vascular compression with resultant infarction, or tumor embolus. So final thoughts is that 3 to 5% of the brain tumors can present as acute stroke. The discrimination is crucial to avoid improper treatment. And if there is a suspicion of intracranial tumor masquerading as acute stroke, contrast MRI or CT should be a part of imaging protocol. In our case, the point favoring stroke mimic was the progressive weakness that is evolved over 6 to 12 hours, absence of speech disturbances, seizure, and altered behavior. And upper limb was involved more than lower limb, and distal was more involved than proximal, and uncrossed hemiplegia. Location, that is midbrain and thalamus. Usually the strokes are rare at this location. Based on the age of presentation and the course, the possibility of ICSOL or demyelination can be thought of. Thank you.
Thank you, Dr. Akshara,
Mahesh?
for a nice case.
Stop sharing the screen.
This
Mahesh?
child, yes, ma'am. This child presented with 1 day history of weakness, affecting first the upper limb and then the lower limb. That is preceding a URA 2 weeks back. So initial first thought was probably it will be a case of transient cerebral arteryopathy because it's stuttering course and preceding infection. We thought of TC and we started on aspirin, and we were contemplating use of steroids. But by the time we got the MRI, we got after 24 hours, stroke was ruled out because the angio was normal and even the location was not that issue of the stroke. And because in view of this capillary spot, we thought of a glioma, and we referred this child for biopsy. This acute presentation over a period of just 1 day was very alarming for us.
One question, sir. Why there is no contrast enhancement of the lesion in this case? What could be the possibility?
All tumors need not enhance brilliantly. Few tumors do not enhance that well, actually.
Dr. Brahim?
I would think I don't have anything to add. I think the clinical presentation, the localization, the differential diagnosis were excellently presented. I think everything nicely done. So as final diagnosis, I don't know exactly what is it, but probably the biopsy will tell us. I think we have to be a little bit more broad, and we have to consider other lesions on the tumor. I don't know, but chronic infection, other differential should be also included. So the biopsy definitely is indicated in this case. But back to the presentation, I think excellent.
Dr. Park?
So yeah, fully agreed with Dr.
Dr. Parak, your connection is getting a bit faint.
Fantastic presentation again. Yes, I mean, definitely. Even if you have a tumor, you can definitely, the tumor itself can cause the clinical manifestations, which may mimic acute deficit like a stroke, or there can be secondary phenomena because of the tumor, which can cause a vascular event. And so that should also always be kept in mind. And so sometimes, this is the management will change depending upon what really is causing the clinical symptoms. So if it is, there can be an emergency, a cerebrovascular accident presenting as an emerging situation, an acute emergency, which may require an acute management to salvage the patient. Okay, so for example, if the tumor is pressing on a major vessel, or it's ruptured and there's been a hemorrhage, catastrophic hemorrhage, especially in the brainstem, and causing respiratory failure or other symptoms, or raised ICT. So you may need to intervene immediately. So definitely what was excellent, and the learning points are there in itself. So apart from the neoplastic process, there can be secondary phenomena which can cause a cerebrovascular issue in the patient.
Absolutely, and that's more likely to present as a stroke mimic, vascular problems in a malignancy rather than a malignancy per se. Yeah, that's absolutely. Thank you so much, and thank you for a wonderful presentation. And we move on, Harsh. We are running short of
Yeah,
time.
so
Move on.
yes, ma'am. So this is now we are moving to a second last case. I invite Dr. Vaishak and his team from Kochi to present the case. And please, you can go ahead and share your slide, Dr. Amol.
My slides visible, sir?
Yes, slides are visible and
Slides
your
are
sound is good. Go ahead.
Slides are not moving actually.
Click on the slide and then go ahead.
Yeah, now we can see the first slide. So, good evening, all. I'm Dr. Amol Jadhav, fellow in pediatric neurology, working in Amrita Institute of Medical Sciences. My moderator for today's session is Dr. Vaishak Anand, Associate Professor, Amrita Institute of Medical Sciences, Cochin. At the outset, I would like to thank everyone, and then especially my mentor, Dr. Vinay KP sir and Dr. Vaishak Anand sir, for giving me this opportunity for presenting on this big platform. So today's title for the case is Solving the Puzzle by the Connecting the Gaps. So we have a case, Master V, 16-year-old boy, second of a non-consanguineous marriage from Kerala. Child presented to us with right-sided hemiparesis with history of fever 2 days prior. So the onset of weakness started as a right upper limb followed by lower limb. It was a sudden onset and then resolved spontaneously after 3 hours. There were no history of facial weakness, no ophthalmoplegia, no bulbar weakness, no sensory disturbances. There was no history of trauma, altered sensorium, no history of seizures, no history of headache, no history of ataxia. Child's birth history and developmental milestones were age appropriate and normal cognition, school going child. Family history was not contributory. General examination, including anthropometric parameters, were normal. On the neurological examination, higher mental functions were within normal limits. Cranial nerve did not reveal any cranial nerve palsy. On the motor examination, bulk and tone was normal. The power charting showed a normal power except for the small muscles of hands and extensor hallucis longus, which were found to be weak bilaterally. Other findings noted were deep tendon reflexes were absent. The sensory system was normal. Cerebellar signs were absent. Gait was normal. And we also found the tremors in bilateral upper limb, which were postural and action kinetic type. To summarize the case, we have a 16-year-old typically developing school-going boy. Transient symptoms, he developed as a sudden onset right hemiparesis, upper limb more than a lower limb, of a duration of 3 hours with the distal upper and lower limb weakness, areflexia, bilateral tremors in upper limbs without sensory symptoms, without visual and hearing impairment. So what are the possibilities? We have a stroke-like episode and neuropathic type of weakness. So with this thought, we have a lot of differentials. First differential was transient ischemic attack, Todd's paralysis, channelopathies including hemiplegic, familial hemiplegic migraine, Fabry's disease, mitochondrial disorders like MELAS, mitochondrial DNA depletion syndromes like Polg mutation, and we also thought of a secondary CNS vasculitis. So moving ahead with the MRI finding, so we found T2 and T2 flare T2 flare was showing hyperintensities in the bilateral symmetrical regions of periventricular and deep white matter involving bilateral frontal, parietal, and temporooccipital region. Also, we found the posterior part of corpus callosum, that is planium, is also having hyperintensities in the T2 and T2 flare region. The similar areas were having a diffusion restriction, which were confluent, and then ADC was showing low signal. So in the evaluation, initial evaluation, blood routines were normal, including metabolic screen was normal. So we have discussed the MRI brain with contrast. There were no contrast enhancement, and then one typical finding was subcortical view fibers were spared, and MRI angiography was normal. So going ahead with the electrophysiology study, NCV was done, which was showing demyelinating sensory motor neuropathic pattern. So we have prolonged distal latencies and slowed conduction velocities in the motor and sensory nerves. So interpretation was a demyelinating type of sensory motor neuropathy of bilateral upper and lower limbs. So again, we thought of the possibilities, what could be possibilities with this MRI and neurophysiology studies. So we again thought of mitochondrial disorder, MELAS versus mitochondrial DNA depletion syndrome, like a Polgy kind of mutation. So point for this diagnosis were stroke-like episodes. There were a diffusion restriction and peripheral neuropathy. But point against were the pattern of diffusion restrictions were different, and then lactate was normal. Also, we thought of a juvenile Krabbe's or MLD, but because the MRI findings were suggestive of more of a leukoencephalopathy and demyelinating type of peripheral neuropathy, but the point against were the stroke-like events and diffusion restriction. Also, we thought of a channelopathies like ATP1A3 and CACNA1A, which also present as a stroke-like episode and peripheral neuropathy. But point against were like normal development this our kid, and then MRI findings were such abnormal MRI. It's very typical for this channelopathies. And then Fabry's disease is another differential, as the child is having stroke-like event, and then MRI findings were also suggestive of some periventricular posterior part of hyperintensities. So, but point against where we have a demyelinating neuropathy in our kid, but in Fabry's we have a painful neuropathy. And then demyelinating disorder was also considered, like Adam, which because there was a history of preceding fever and weakness, and then confluent lesions were noticed in the MRI. But with such a fast recovery and diffusion restriction were against. So genetics, finally, we have done ahead with the genetics, and then pathogenic mutation in GJB1, which was related with the X-linked Charcot-Marie-Tooth disease, found pathogenic. So mother was a heterogeneous carrier and asymptomatic. So regarding CMTX1 is an X-linked dominant in condition which related to connexin 32, a transmembrane protein on the oligodendrocyte side of astrocyte and oligodendrocyte junction. That is involved in the formation of gap junction channels in the vertebrate. Mutation in the GJB1 gene that encodes the connexin 32 are considered to be the reason for CMTX1. Mechanistically, this mutation may cause connexin 32 dysfunction, thereby inhibiting assembly or pore formation of transmembrane channel, reducing the luminal diameter of the channels. These fragile channels may lead to temporary functional derangement of gap junctions with increased water content and possibly intramyelinic edema, which can be partially confirmed by the such rapid recovery and abnormal diffusion restriction on the patient's MRI. So this is what we found in a pes cavus deformity in CMTX1, and we have already discussed like bilateral periventricular symmetrical confluent hyperintense lesions, stroke-like attacks in the axial flare images, and then characteristically subcortical fibers are preserved. The CMTX1 is usually present as a late childhood and adolescent. The age range was 6 to 26 years.
30 seconds
Compared to
remaining.
women, CMTX1 has tendency to occur earlier in the men, and course is more severe. Gait disturbance were most common initial symptom. The small proportion of patients present with a sensory neural hearing loss, tremors in hands, pathological fractures, recurrent CNS finding, and reversible change in the white matter. We have done the systemic review of these patients, and then we found that CNS manifestations, the most prominent manifestations were facial and lingual limb weakness, dysarthria, dysphagia, facial and limb numbness, ataxia, aphasia, and then pyramidal signs were also noticed in the few cases. Predisposing factors were infection or fever, travel to high altitude, intensive exercise, trauma, poor sleep, thyroid malfunction, puerperium, hyperventilation, and exposure to strong sunshine. PNS manifestations were hyporeflexia, areflexia, pace chaos, hamartose, muscle atrophy, weakness in the distal limb, diminished or absent sense. Treatment they gave as a corticosteroid but IVIG, but there were no good evidence to support this treatment. MRI lesions we already discussed, like a bilateral deep white matter lesions, and corpus callosum, even splenium of corpus callosum was characteristically involved in this. Take home message is acute focal neurological deficits in children are not always vascular. Stroke-like episodes should be considered in any child presenting with hemiparesis. Channelopathy should be considered in multineuroaxial involvement like mitochondrial cytopathies, and GJB1 mutation to be considered in neuropathies with stroke-like episode. Thank you.
Yeah, so very nice case, Dr. Vaishak, please, your comments.
Thank you, Dr. Amol, for that concise presentation. So this case was interesting because there is a discordancy at all levels. The symptom he presented was of a stroke or a transient ischemic attack, but the examination revealed there was no contract sign, but we got element signs. And MRI was again discordant. MRI was showing a diffuse and symmetric involvement, more like a leukoencephalopathy. So the sign, symptom, and imaging were not matching each other. With this stroke-like episode, the initial thought that we had was kind of a mitochondrial disease like MELAS, but apart from the stroke-like episode, the MRI picture was not fitting into a MELAS. The typical MRI picture of a MELAS we already saw Dr. Mohan Sundarmat, Dr. Kamila has shown in their case, but this picture was completely different. Then the possibilities like familial hemolytic migraine, ATP1, A3, CSC, NA1, these all were thought of, but again, MRI picture was not fitting in those entities. So once the exome report was available, all the disparities were fitting into the right place because the stroke-like episodes are well known associated with Charcot-Marie-Tooth X, that is connecting mutations. But the uniqueness is that most of the cases of CMTX, they can have stroke-like episode after neuropathy sets in. But in our case, stroke-like episode was the presentation itself. Peripheral neuropathy was not a complaint to the child, and it was only an examination finding. So this was 2 years back, and after he is not on any treatment. We, apart from diagnosing this, we didn't give any treatment. For last 2 years, he's symptom-free without any treatment, and functionally also he's well thriving. He's not having any functional deficit at present. Thank you.
Thank you. Dr. Brahim?
Yeah, I think, thank you for this very nice case. I think that the clinical presentation is again very interesting. So it's the transit deficit, which is non-specific, and we have to raise several differential diagnoses as stroke or stroke mimic or others. But I think the clue here is the absent deep tender reflexes, such with this neuropathy. So this may raise suspicion of other differential diagnoses. So with the MRI, I think after the MRI, things are more clear. I think the MRI is typical for bilateral white matter lesion, sparing the U fibers, and we can call it under the umbrella of leukodystrophy. So in this leukodystrophy plus peripheral neuropathy, CNT is one of the X-linked is one of the possible differential diagnoses. So now things are more clear. But back to the case of the presentation, I think the mechanism of stroke in this patient, as you said, is probably, even there is no findings of the MRI, but it's one of the stroke-like or metabolic demand triggered by fever or the febrile illness. Even there is no clear MRI abnormality. MRI showed only white matter, but I think we have increased demand of ATP by the stress or the fever, and this may cause transit stroke or stroke-like. Thank you.
Dr. Manish?
So again, a beautiful case and a lot of learning points here. And we've seen almost every atypical presentation which looks like stroke, and then it turns out to be either a demyelination or a neoplastic, or sometimes stroke mimic. That's very true here, and I fully agree with Dr. Tibarki. The clinical presentation is definitely not very typical of what cerebrovascular event would look like, for example, arterial ischemic stroke or an acute hemorrhage. But then, yes, there were many other things to take into account, and the peripheral neuropathy, the radiological. So the take-home point for me is definitely you need to examine them clinically very well. So if for all the residents here, if someone comes with an acute examining, then imaging, you must have a hypothesis to prove that's what is required, and definitely then you reach to the diagnosis. So that's important.
Thank you. Harsh, there's some questions.
Yeah, I have asked Dr. Vaishak to type the answer, ma'am.
Okay, okay. Thank you. Thank you. So we can go to the last case because we're running behind.
Yes,
schedule.
yes, ma'am. So I invite our last case. It's a team from PGIMR Chandigarh. I invite Dr. Santosh to present the case, and Dr. Renu Sudhar would be the moderator.
Good evening, sir. Is my screen visible? Am I audible, sir?
Yes, please. Your slides are visible.
Good evening, everyone. So myself, Dr. Santosh Mishra, I'm a senior resident at PGI Chandigarh, and I am presenting this case under the guidance of Dr. Renu. And so, coming to the case, Miss A, 13 years gone, right-handed, presented to us with a recurrent episodes of weakness of either half of the body from 1 year of age, and currently presented to us with a similar episode 9 days back.
Dr. Santosh, can you make it a slideshow?
It's a slideshow only, sir.
Okay, it is not visible then.
Is it visible now?
No.
Dr. Manasi, can you help?
Is it visible?
The slides are visible, so you can continue, not an issue.
One second. What you do is stop sharing the screen. Stop sharing. Then you share your whole screen.
Okay, ma'am.
Stop sharing first. First, stop share. Stop share the screen, beta. Stop sharing the screen. You should, now you share your screen. Don't share a window. Share your screen. Share karo.
Yes,
Share your whole screen. And then maximize your PPT. Ho jayega. Okay.
Is it visible now?
Can the screen
Yes,
is
now
visible?
visible.
Can you go back and
It's
forth a
visible.
couple of slides? Yeah, okay.
So, antenatal and the body history was normal, and at 9 months of age, the child had a unprovoked seizure, and parents also complained about a developmental delay in form of partial neck control, cooing, and a social smile. So the child was started on anti-seizure medication. At 1 year of age, the child had a decreased acute onset decreased movement of the right upper limb and the lower limb, which progressed to the opposite side within 24 hours. However, there was a spontaneous recovery in 2 weeks without any deficit. And similar 8 episodes occurred in the next 4 years, after which they came to PGI, and the further evaluation was done and managed accordingly. And after that, these symptoms were passive for next 6 years. However, at the current age of 13 years, she again came with a complaint of acute onset weakness of her left upper lip and the lower limb, which was progressive in nature, and the maximum weakness was on the 4th day of the illness. Later, that became static and improved by 2 weeks without any deficit. And the current milestone at 13 years, is she can only walk without support, can draw lines, 2 to 3 meaningful words, can, knows her name and plays with sibling and indicates toilet. So there is a profound developmental delay at 13 years of age. On negative history, there is no history of headache, vomiting, double vision, blurring of vision, or breakthrough seizure, impaired consciousness during these episodes, history of any abnormal or involuntary movements, facial deviation, drooling, asymmetry, feeding and swallowing issues, or bowel and bladder involvement. On etiological side, there is no history of any specific triggers for these events, no history of rashes, varicella in the recent past, joint pain or arthropathy, no history of a cardiac diseases, there is no bleeding manifestation and no history of a migraine in the family. And she was the firstborn through non-consanguineous marriage in the family. On examination, vitals were stable. Anthropometry-wise, child was normal. There was no pallor, cyanosis, or lymphadenopathy, and there was no sign of a micronutrient deficiency. And head-to-toe examination was normal, and she had a normal head circumference. No neurocutaneous markers were there, and child was non-syndromic. On neurological examination, in limited higher mental function assessment, it was normal. She can only speak around 3 to 4 words because of her developmental delay. On cranial nerve examination was normal. There is no facial asymmetry or no ophthalmoplegia. On motor examination, tone was reduced in the left upper limb and the lower limb, and the power was also limited to 2/5 in both upper limb as well as a lower limb. So to summarize the case, 13 years girl with profound global developmental delay with developmental quotient of around 10 with infantile onset epilepsy in remission at present with recurrent episode of hemiparesis onset from 1 year of age, shifting laterality in the right, sometime in the left or a bilateral with spontaneous recovery over 1 to 2 weeks with 8 such episodes till date. On examination, she had a normal head size and had a left hemiparesis. So, in view of our symptomatology, which were not of the classical stroke, we had to think of other differentials like stroke mimickers. So, in that, channelopathies, epilepsy, migraine, metabolic strokes, and electrolyte disturbances were the possibilities. So, in view of that, we investigated the child and the radio imaging. So, no evidence of an infarct or a bleed. Cardiac workup was normal, thrombotic workup was normal, metabolic profile was normal, and EEG done was also normal record, and the fundus examination was also normal. So all the reports came within the normal limit. So we are only left with the channelopathies, and because of the migrating pattern of the weakness, we thought about the ATP1A3 mutation, and the targeted sequencing was done for the same, and it turned out to be a ATP1A3 mutation at the exon 18. So, talking briefly on the ATP1A3 mutation, the function of ATP1A3 is to pump sodium and potassium, so thereby maintaining to use ATP to pump the sodium and potassium, thereby maintaining an electrogradient across the neural membrane. So, if there is a mutation at this ATP1A3 site, so there will be altered function of a sodium potassium ATPase channel, and because of the dysfunction of this pump, there will be an increase in the intracellular calcium, so causing a cellular death, as well as there will be inhibition of a potassium ATP channel, so causing a sustained excitatory state of the cell. So because of this pathophysiology, there will be the different symptoms. So there is a expanded broad symptoms related to this ATP1A3 related disorder, from the alternating hemiplegia of a childhood to the rapid onset dystonia and Parkinsonism with cerebellar ataxia, with pes cavus, optic atrophy, with sensorineural hearing loss, and the overlapping symptoms as well. Regarding the alternating hemiplegia of a childhood, it is usually in the early onset. Usually symptoms start before the 18 months of age. There will be repeated attack of a hemiplegia involving either side of the body. Sometimes it might be a bilateral hemiplegic or a quadriplegic as a generalization of the hemiplegic episodes, or bilateral from the beginning. There might be a paroxysmal disturbances along with the autonomic dysfunction which might go unnoticed. And the immediate disappearance of the symptoms upon sleeping can occur, and which can later can resume after 10 to 20 minutes after waking. So this is again a classical. And there is evidence of a developmental delay and the neurological abnormalities like a choreotyped dystonic or ataxic movement. And these symptoms should not be attributed to any other disorder. In our patient, these red symptoms were there. talking about the management part, no disease modifying drugs has been discovered yet. However, there are multiple agents has been tried till date to ameliorate the symptoms. However, no results were not so promising, and so in our index trial, we continued with flunarizine, topiramate, clonazepam, CoQ supplementation, and steroid therapy was also tried. Thank you for your attention.
Yeah, thank you. Dr. Renu Sudhar, please your comments.
Thank you, Dr. Santosh, for this presentation. I think what was very important in this child was, like, first, when we have seen her at 3.5 years of age, the typical symptom of stroke was in the form of progressive weakness. So her weakness would progress over few days, and then within the weakness itself, the symptom would fluctuate, that her symptoms would be better in sleep and worsen in awake state. And within the same episode, it progressed to opposite sides. So that makes us think of stroke mimic, because these symptoms cannot be explained with the anatomical territory involvement in a vascular territory fashion. So that's why a stroke mimic was a very strong possibility. And a normal image would rule out, normal image with diffusion weighted image, rule out a vascular entity here. So definitely a channelopathy would be a very important differential diagnosis. Among those, familial hemiplegic migraine is a close mimic, though usually familial hemiplegic migraine presents in later age and alternating hemiplegia of childhood presents in infancy. So I think that is a take-home message, that multiple episodes progressing from one side to other side to quadriplegia and very high frequency and recovery without any residual deficits should make us think about channelopathy in cases who present like a stroke. And we had a long-term follow-up of this patient over 8 years. She was maintained on 2 drugs initially, flunarizine and topiramate. However, she had a worsening and recurrence of symptoms at present. So thank you so much for giving us this opportunity to present this case.
Thank you, Renu. Dr. Brahim, I know you also must be tired. So many cases, and we are running 33 minutes behind. So many cases.
No, today is a clinic day, so so always busy in the clinic. Now, very interesting case. I totally agree that the presentation or the semiology is not typical for cerebrovascular events. So from the beginning, I think we can rule out any vascular problem. So the whole picture, probably the age of onset, the global developmental delay point to genetic or metabolic disorder. So this is one. Plus the MRI is negative. This is also very important, but I think we have to be more broad in our differential at the first presentation. So mitochondrial can be there, moya disease can be there, etc. What is I may miss any eye problem, paroxysmal event, or any dysautonomia. I didn't heard about dysautonomia or any eye paroxysmal event, which are typical for alternating hemiplegic in children. So I think, again, the clinical evaluation is extremely important. What is unusual for me that the second attack happened around 11 years after the first one, without treatment. I think this is very unusual, unless I missed something. But the whole presentation, I think, is typical for alternating hemiplegia of childhood. Thank you.
Thank you, Dr. Manish.
So great case again, and no comments right now because we're running out of time, and Dr. Tibarki and Renu have already, the learning points are very obvious. Again, you need to have an hypothesis. You need to discuss the differentials. Certainly, that was the take-home point here. And then,
I would
genetics or something would definitely
thanks.
prove your point.
I'll give I'll give you 1 minute to both of you to think about some take-home messages while Dr. Mansi, I will request you to share the conference slide and the certificates. So you just think about some take-home messages for the entire group. I request the experts to, the certificates will be mailed to you, and I would request the experts to make some take-home messages overall. And while I thank all the presenters, and majority of the preceptors have been my own students, so their students are presenting, so makes me feel more ancient, but makes me feel very proud and happy. And all this will be mailed to you, the certificates, and I request you to join in the annual conference 8th, 9th and 10th February 2024 in CMC Vellore, and feast of academics awaits you. And thank you so much, Manasi, and I will request Dr. Brahim, I'm very grateful to you for spending so much time. We requested for your 1.5 hours, now it's beyond 2 hours. And, we wanted to limit to 6, but there was so much interest, so we had to accommodate our colleagues because we have to encourage all of them. Really grateful to you for your expert comments and your taking time out. So your take-home messages, besides the gratitude we all from AOC in India have for you.
Yeah, thank you very much for the invitation. My pleasure, and I learn a lot from this case. I think the first message that in children, even we recognize more and more stroke in children, but still is a rare condition, and most of the cases are stroke mimickers. So I think it's extremely important to recognize very early those stroke mimickers. Whatever, sometimes it can be only hypoglycemia, and it need very specific and urgent treatment. So we have to be very broad in our differential diagnosis. And again, after years of experience, I think the clinical evaluation is extremely important to guide us for the investigation. So again, we have to evaluate. Yes, we are in the emergency situation, but again, we need full clinical evaluation. And from that, I know that in the emergency department, we are limited in terms of imaging. Most of the time, we are doing only CT, where there is no available MRI. It's difficult sometimes, but again, if we don't have risk factors, if we have unusual presentation, we have to think about stroke mimicker and not to miss treatable condition.
Thank
you.
Thank you. Dr. Manish, thank you so much for pitching in.
So thank you so much, ma'am, and thank you so much, Harsh, and the whole team, Mahesh, everybody. So I'm actually a host here, Dr. Tibarki, and it was a fantastic experience with you and everybody else. So all of these cases were from real experts. They're my colleagues, and I know they're fantastic people. So thank you so much, ma'am. And the only thing I always stress on the fact that we must stress on our clinical skills. We must have an hypothesis based on history, rule them out one by one, and then the stroke mimics can be teased apart from the real stroke, certainly. And of course, experience builds up things. So listen to these cases, attend these CMEs and these sessions, and we'll all be wiser. We'll all be wiser together. Thank you so much.
Thank you, Dr. Manish. And I think even in 2023, going to 2024, your history taking is the most important, which is going to guide your examination, which will guide you your series of investigations. And I think that is very important. And what Dr. Manish pointed out once, that, common things, atypical presentations to be thought about, like he was mentioning neurotuberculosis in our country. And then you think of uncommon things, but you do think, and other thing about the neuropathy was being mentioned. neuropathy, many times you will not find any symptoms. You'll have to examine and find, and especially when you're taking a family history, you can't take a family history on history for neuropathy. You have to examine the family members. So, I mean, those small things have to be kept important, and you have to understand, when you have to send the mitochondrial panel, and, that has to be kept in mind, because your normal exome is not going to work out. So all that is important. And thank you so much. And Dr. Rahim, you may not know, Mahesh we started the first DM program in 2004. Mahesh was our first pass out, the first candidate. And then Raju, who was also there. Harsh is also our alumni. Vaishak is our alumni. Gautam is our alumni. Mohan is currently studying. Pratik Panda is also. That is why, all these people are going and they become big in their own places, because we have 59 people who have gone and spread across India. Plus also we have some in the Middle East. Some of them are in UK, some are in Canada and US. So they're all spread around. So that's how it's going on. And we will seek collaborations, and you can encourage your students to present cases also. So we are having acute stroke, interesting cases next week, and then recurrent stroke the week after. Thank you so much. And I'll hand over to Mahesh for formal bye-bye. And thanks, Harsh. Harsh, one message. Sorry. You have to also give. Now you're moderating one take-home message before we wind up.
I think, ma'am, all the messages already we covered. So that's fine.
Thank
Yeah.
you. Thanks. Mahesh.
I thank both the experts for their valuable inputs, and Dr. Harsh for nicely moderating the session. And next week again we'll meet with interesting cases of acute and recurrent strokes. I request all the members
Next week is acute. Next week is acute. Recurrent is the week after. Yeah.
Yes. I request all the members to email your interesting cases. We can shortlist 6 or 7 cases again for next week. I expect all of you to attend the next meeting also. Thank you.
Thank you so much.
Right.
Thanks a lot.
Bye-bye.
Bye.
Thank you, ma'am. Thank you. Thank you, sir. Bye.
Thank you. Bye.